Good afternoon. Thank you for joining us for our Ask HMA Experts Medicare Town Hall. This webinar is a little bit different than our typical webinar in that we are solely focused on the Q&A portion of the webinar because, as we know, with so much change happening in DC and in healthcare markets around the country, there are a lot of questions about Medicare. So we are thrilled to have a fantastic panel of our HMA colleagues today. Our HMA Medicare team includes experts from HMA, from Wakely, from Levitt Partners, and others who are under the HMA umbrella of Medicare experts. And so let me just briefly introduce our team today, and all of their bios can be found on our website. Amy Bisano is a nationally recognized health policy expert and senior executive with more than 2 decades of experience shaping Medicare strategy, payment systems, and value-based care innovation. She's the managing director of Medicare services at HMA, and she previously was a deputy director of CMMI and held multiple senior roles at CMS. Shannon DeRay is a healthcare policy advisor and legal expert with a strong background in Medicare and Medicaid reimbursement, federal regulations, and multi-sector collaborations. Shannon brings a blend of legal, research, and policy experience, and she advises provider systems and analyzes key CMS programs and is working in support of national health policy initiatives. Zach Gaumer is a veteran health policy analyst and project manager with 2 decades of experience in Medicare payment systems, healthcare data analysis, and federal policy development. He has prior expertise from his time at MedPAC and other federal and state focused roles, and so does a lot of publishing, brings a data-driven approach to tackling complex healthcare financing challenges. Kevin Kirby is a Medicare policy expert with more than 25 years of experience advising on reimbursement strategy, drug pricing, and regulatory issues across pharmaceutical and biotech sectors. He draws on his extensive knowledge of Medicare Parts B and D, Medicaid pharmacy policy, and federal healthcare legislation to support clients. Holly Michaels Fisher is a healthcare leader and strategist with extensive experience developing and managing Medicare and Medicaid plans, special needs plans, and long-term services and supports. She's led large-scale program expansions in the private sector, including for D-SNP growth, and has built groundbreaking care models for complex and vulnerable populations. And Tim Murray is a Medicare-focused actuary with more than 20 years of experience supporting health plans and provider groups on strategy, pricing, and financial forecasting within Medicare Advantage. He's a principal at Wakely and brings in-depth expertise leading actuarial functions, previously at a Medicare Advantage plan, and advising clients on bidding policy changes and growth opportunities. So, as you can see, this is a panel that can probably answer just about any question. So let's go ahead and get to it. We had over 100 questions submitted from those who registered. So the way we're going to do this is take the first chunk of time to answer the questions that were submitted already. And then we'll leave time at the end for fresh new questions as you come up with new questions and thoughts as we go along. Please feel free to post those in the Q&A section, and we will work those into the conversation. We will be recording this, and if you registered for this, you will get an email with the recording, so feel free to share that if it's helpful. Since we don't really have slides, we won't be sharing the slides, but happy to follow up if other questions come up after this event. So let's go to the questions. So first off, lots of questions just kind of generally about what's happening. So Shannon, let me ask you first, what major Medicare policy changes, reforms, things like reforms to prior authorization, utilization management, parity, other policy changes, what can we expect right now when we look at the agenda, both in Congress and in the administration under new leadership?
Great. Thanks, Jen. And good to be with you all today. So, I want to kind of separate out this answer and talk a little bit about kind of what's top of mind from the legislative perspective in terms of what's going on in Congress, and then a little bit about what we're starting to see from the administration in terms of Medicare fee-for-service and Medicare Advantage. So, for a number of folks, I know budget reconciliation is top of mind. There is an expected committee process next week on May 9th, kind of moving that process forward. And there's still, despite kind of where we are at in that process, a lot of uncertainty on what is going to make it into this bill and in what form. Folks will be aware there is a significant difference between the House and the Senate in terms of where they landed in instructions for the level of savings that they need to achieve through this package, with the Senate landing at around $1 billion and the House landing at around $880 billion. So, we are hearing, from folks on the Hill that are working on these packages that they're still waiting on, what exactly can go in, what exactly do potential changes, especially in Medicaid, where significant savings are expected to be achieved. What are those policies that will go into that package? But a question that I get a lot from clients is, how is this related to Medicare? What related to Medicare could make it into a budget reconciliation package? And right now, some of that uncertainty that is coming is because there isn't really, to our understanding, a final answer from the White House as to whether anything related to Medicare will go into the budget reconciliation package. President Trump in the past has been, fairly strong on the fact that he doesn't want to touch Medicare as part of this particular package. And whether or not it's a policy that could be viewed as pro-beneficiary or an improvement to Medicare in some way for providers, there's still not quite a final answer on whether or not Medicare is in. So when we think about those potential policies, folks have asked, on the savings side, is there potential to see Medicare site neutral, some changes in Medicare Advantage for targeted reductions in upcoding? We have those at sort of a medium level of expected inclusion, but I think at this point, right, with that uncertainty, maybe less likely to see those changes in Medicare. For a number of providers, right, there has been in Medicare fee-for-service kind of two failures over the last 6 months to include a patch in the Medicare physician fee schedule to kind of address the significant cuts within that fee schedule. Congress has acted a number of times since 2020 to adjust the fee schedule to make sure that there is sufficient funding for providers in Medicare fee-for-service. But in the end of year package and then in the CR in March, Congress was not able to reach agreement to kind of continue that patch. So, a key question is, will they include something which is a coster rather than a saver in terms of that patch in this package? And I think, it's challenging given the level of savings, especially that the House is looking to achieve, to foresee them doing that. But it is a top question for providers. Another is on telehealth. Telehealth is extended through end of September 2025. Whether or not that could be addressed in reconciliation, again, an open question. So all of that to say, there's still a lot of negotiation that is going on the reconciliation package in Congress. We expect to learn more in the next couple of weeks on specific policies that will make it into that package. And there is a target date to try to pass that legislation by the end of September, which is when the budget reconciliation instructions expire, and also kind of in line with the expectations on the debt ceiling. So a lot going on in Congress over the next couple of weeks, definitely worth watching from a Medicare perspective, and then obviously with all the potential changes in Medicaid as well. When we think about this administration and their priorities in Medicare, we have kind of limited actual, rules to go to, proposed regulations, finalized regulations to say what they will definitively do in Medicare Advantage or in Medicare fee-for-service. But there's a kind of a few things that we can glean based on the experiences in the first Trump administration, as well as what they have done so far. We saw a focus in the first Trump administration on how to reduce administrative burden, how to simplify regulation. And in the first tranche of fee-for-service payment schedules that came out a few weeks ago, there was an RFI included in all of them, which asked providers in particular to come back and say, what are aspects that we should look to change about these regulations to reduce some of those administrative burdens and to simplify regulations? The Trump administration and President Trump put out an executive order that specifically requires that for every new regulation, 10 are removed, which has its own kind of feasibility issues. But one way that they're looking to do that is to get feedback from stakeholders on how they might simplify some of those regulations. So across fee-for-service and Medicare Advantage, thinking about, what are some administrative burdens, whether it's for providers or plans, that the administration can be involved in addressing maybe one area. When you think about things like prior authorization, upcoding, utilization management, these are kind of other key issues. There's been a lot of congressional bipartisan interest in addressing some of these issues. These are loud issues in the minds of many beneficiaries. So, I won't say I have the specifics on what I think the administration will do in these areas, but given the attention they've received, I think, with time we may see additional action from the Trump administration on them. Jen, happy to answer any other questions, or if folks have anything else they want to add, definitely welcome that.
Yeah, let me bring Amy into that conversation in terms of, the regulatory agenda. Thinking the question is sort of around regulatory operational headwinds, right? Thinking, so maybe particularly around fee for service, what type of changes between fee for service and then, CMMI are you expecting?
Yeah, thanks, Jen. And Shannon did a great job sort of outlining many of those things, but and she alluded to sort of the payment rules are just starting to come out. I think what we see this year may be some soft signals of where they want to be going, but the broader or bigger impact on their agenda would be coming, in the following year, just given the lead time in developing some of these, excuse me, policies that they may want to be doing on rolling back regulations or thinking about other flexibilities, reducing regulatory burden and all. So I think those are things that may start to come this year, but really you also need a full team of folks in place, which the administration still gathering in the CMS side and HHS side of things to really develop and implement on their particular agenda. So I think it'll be over this year and next year. It takes a couple of years to get some of these things going, especially any of the major changes. And given what we know that's already on their agenda about whether it be the drug price negotiations or other things that they are doing and have indicated that they want to continue to do, that they'll be working on that. I think CMMI has a little bit more flexibility to move a little faster given the way the models are developed outside of the rulemaking cycle. So I would expect to be seeing more from them in the short term, whether it be first, we saw first they're pulling down some models and indication that they've done a portfolio review. They're working on a new strategy and then new models coming out. So I think that over the next few months, we'll get a sense of what that looks like, which also can give us some additional hints in terms of priorities about where they want to be using their resources, where they think it's most important. Do they want to be working, building out ACOs further? Do they want to be potentially doing something in the Medicare Advantage space, given that, the VBID model no longer exists? And is there other work they want to be doing there? In the drug pricing space, there's a lot of different things they could be doing. And then, of course, there's always the interest and request to be doing more in the specialty model space as well. So a lot that they can be doing that may be coming on. But I think one of the overarching themes will be the sort of savings and the fiscal, being tight on the fiscal side of that, especially from the Innovation Center, if that's really when they want to get back to the basics of what the Innovation Center authority is of reducing costs or increasing quality. So I think those are some things we'll be seeing over the short term, and getting little hints along the way as more and more documents come out from the administration.
Hopefully both increasing quality and reducing costs. Let me ask Holly and Tim, obviously lots of questions about Medicare Advantage. So just kind of rolling some of these together. Holly, maybe I'll go to you first. What kind of policy regulatory changes are you expecting, and anything different than what Shannon and Amy have said in terms of your expectations, or what you might be looking for as trends that you'd expect to shape the program?
I mean, I think the one thing is a question here in terms of Dr. Oz, and that, you know, during his, when he was first appointed, he did acknowledge that he is going to come down on Medicare Advantage plans in terms of reimbursement. And we know that this has certainly been an issue for a long time. I think we've heard focus on both deregulation at the same time, also on program integrity, and therefore an increase in audits. So, while we haven't heard anything specifically about RADV audits or other changes, I do think that it is likely that we'll see continued focus there. Will it be different? I don't know. But I think that there's an opportunity here in some ways from an operational perspective for plans to really begin to think about how do they leverage interoperability, digital quality, so that they're able to actually much faster, more completely obtain the data necessary to validate codes before they submit them as part of the whole HCC submission and things like that. But I do think that we should expect increased focus overall, program integrity, fraud, waste, and abuse, and that's something that plans should be thinking about doubling down on to prepare themselves and really to get ahead of it so that they're monitoring themselves, whether it be through changes of some of their operational procedures or increasing some of the audits of areas that we know are important to the government. I know, Tim?
Yeah, no, totally agree with Holly. I would add just a couple more specific points on risk adjustment. I would expect there to be continued scrutiny. I think that's a very intentional signal from Dr. Oz and the administration, both to signal where they're going and also to ensure that the very high effective growth rate that came out is not perceived inaccurately as a handout to MA plans. As far as the mechanisms that CMS uses to explore further scrutiny and risk adjustment, I think there's a number of potential paths on the menu. One of them that's been discussed in the advance notice and final rate announcement is shifting to an encounter data model. Now that encounter data has improved in terms of quality quite a bit over the last decade or so that it's been relevant, it's plausible to see transition to an encounter data model over a number of years. That could be one path that's explored. There's been discussions of alternate approaches, such as an inference-based risk adjustment model, which would take a lot of the documentation gaming out of the system. I think that could be a path that's explored through a variety of models. It'll be interesting to see where they go, but I certainly expect that to be an intensive area of focus. And I think looking at all the various aspects of MA, benchmark calculations, star ratings, I think it's all on the menu to be explored further. It'll be really interesting to see where the administration goes.
So there were lots of questions on various aspects of supplemental benefits. So, questions on behavioral health, questions on social needs services, HRSN, lots of questions of that nature. So Tim, do you want to talk a little bit maybe specifically about what you might see there in terms of supplemental benefits and sort of compliance and benefit design around those issues?
Yeah, sure. So we did see quite a massive expansion in benefit flexibility during Trump 1. Explosive growth in the value of supplemental benefits and variety of supplemental benefits. And I think when we look back over that time, certainly an exciting period of innovation, but also are struggling with being able to evaluate with all the noise and all the inputs, what's actually driving value and what's not. And so when you look at the MedPAC reports highlighting that MA plan rebate revenue is in the neighborhood of $200 PMPM, and you consider kind of what value is CMS getting for that investment, the story is not quite as clean as would be ideal. So CMS has taken steps over the last few years to collect and clarify that they expect incremental data to be provided around the utilization of those supplemental benefits. We at Wakely, with our care management team, has worked to aggregate some of those data sets across our clients. And there'll be some interesting findings that are going to come from those data sets as they continue to improve. I expect a more rigorous evaluation of the value of those supplemental benefits as we look over the next few years. And I expect there'd be more kind of a policy emphasis to make sure that these dollars are flowing into solutions that are actually driving real value as opposed to just kind of marketing appeal. This is a longstanding issue that CMS and plans have grappled with, and I can see that being like risk adjustment, an area that CMS looks to make sure that they're getting value for their dollar.
That makes sense. I will call attention to the fact that in the Q&A, there's already questions being answered in there. Thank you, Zach and Shannon. So Tim, there's a specific question about risk adjustment, so I might just point your attention to that. But let me move to, let's see, where was I in? Um, Risk-based models. So questions around value-based care arrangements, kind of where those might be evolving, with health plans, how they should be thinking about these strategies moving forward in terms of, facing some of the operational challenges. Thoughts on kind of risk-based models and what the environment might be there. Tim, maybe I'd go to you first, although Holly and Amy, you may have other thoughts as well on that question.
Yeah, I was engrossed in the risk adjustment question.
Sorry, I realized I pointed you there and then I thought I was going to a different question. All right.
Holly, do you want to start us off on this one?
Sure. I mean, I think that as I'm trying to sort of think of Jen how to really sort of crystallize that question more succinctly, it really is where do we think it's going to go? I personally think we're going to just see increased pressure around risk scoring, that much of what some of the practices that are done today, I think may not be allowed in the future. And that, there's a question there in terms of, is this actually going to impact sort of what year-over-year scores, things like that? I think the answer is yes, that we're going to start to see the potential for that. I don't know, Tim, if you agree.
Yeah, I mean, I think there's been a lot of discussions historically, some that's come up in the rumor mill, looking at home risk assessments as an example, if not also if a diagnosis is captured in a home risk assessment and not associated with a subsequent claim or encounter. That's obviously gotten a lot of attention over the years from a variety of studies and reports. So that could be under the microscope. CMS could consider adaptation of the model to consider whether or not certain codes should be admissible from various sources. So I think there's a lot of different strategies and mechanisms that CMS can explore. I would expect them to take a measured and kind of transitional approach like they have with V28 and other historical risk score model changes. But I guess the unique aspect of this current environment is that it seems to be very strongly bipartisan as an area that merits incremental scrutiny. So I think there's a lot of momentum in that space.
I would just add from the fee-for-service side, in terms of risk-based arrangements, I think there will continue to be more models that are looking for providers to take on risk. I think that's how you need those to achieve the savings. And so, whether it be modifications to MSSP, the next iteration of ACO REACH, modifying other models that may not have risk-based parts to it, I think they'll continue to see that's part of the evolution of the value-based movement to value-based care. And so wanting to have providers, other entities, taking on that risk for the management of the care of those patients. So I think it'll be interesting to see what that looks like and, where they go for ACO REACH, both sort of the general population, but, the high needs population that had gotten a lot of attention, and other really expensive, complicated patients, and having, if there'll be in opportunities for more organizations to take on risk to manage their care.
Great. Zach, maybe I'll go to you next around provider reimbursement questions around changes, what kind of changes to anticipate, and I guess kind of reading the tea leaves from what you've seen so far, how might that impact providers, and then ultimately, of course, how that might impact Medicare Advantage organizations.
Sure, absolutely here. So we've just gone through kind of the first wave of Medicare proposed rules on the fee-for-service side, and it's started to signal what the new administration is going to be thinking about and working on. Generally, I'll say that we've started to see, of course, reduced regulatory burden as a focus, improving transparency, and then streamlining quality measurement. We've seen that across the early proposed rules that have come out, and I would expect to see more and more of that as the year plans out here, with outpatient and physician fee schedule coming out over the summer. But I'll talk a little bit about the inpatient payment system and the reg that came out a couple weeks ago on that. A couple of interesting things in there. So, they're looking at about a 2.4% payment increase for 2026. That's proposed. This is a little bit lower than what we saw for the MA plan benchmarks, going up about 5 or more percent. The big reason for the difference is not necessarily inpatient, however, it's more of an outpatient phenomenon. So that's the delta most likely between the two. Although I think the hospital industry will certainly point that out in their comments on the proposed rule. Other things that I've seen in there are, we're seeing a big increase in the uncompensated care payments to hospitals. That's being driven mostly by an estimate by CMS that the uninsured population will increase over the next year. And another thing that's very telling as a signal for where payment and reimbursement might be going for Medicare is the administration has proposed putting Medicare Advantage claims data into some of the fee-for-service quality measurement or measures such as the readmissions measure. And I think that could have some impact on individual hospitals that have large MA populations. They might see their readmission penalties change slightly, but that's something in general as a big picture item to consider as MA claims get built into potentially the reimbursement mechanisms that are out there for inpatient or outpatient. Something to keep an eye on. Two other things that weren't in the rule, but I think are things that I'm thinking about for the rest of the year here. There's a lot of talk about site neutral reimbursement and how Congress might make some changes on that, and then CMS making corresponding changes later on. The other thing is I'm anticipating that we'll see some movement from inpatient to the outpatient. So there might be some regulatory encouragement for cases to go to the outpatient side. That happened with Trump 1, and it could happen again. I'd say it's very likely to happen again to some degree. And I'll pass it along to others that might have thoughts about the provider reimbursement side.
I would just add what Shannon teed up earlier on the physician side of payments, where they face these cuts. Congress has an act. It's, the physician payment rule will be coming out late June, July timeframe. What does that look like on the sort of the sustainability of physicians be able to deal with those continued cuts? And so is there something that the administration could try to do? It seems very unlikely given the clear statutory authority, but are there other policies in place? Will they want to continue to look at primary care payments? Will they want to continue, how robust will the misvalued code initiative be? So I think there's a lot on the physician side, but as Shannon said, mostly on the congressional side, but I think CMS likely to be looking at what they can be doing there to address some of those issues and what they're hearing from the different physician communities.
Yeah, and Amy, to your point, right? Like even in the first Trump administration, the unfortunate part of the fee schedule is that essentially where you make significant changes in one area, you're essentially picking winners and losers among different types of clinicians. But there were really, significant changes to E&M coding with a real prioritization around how to improve primary care and some of those visits that had an impact on key specialties within the fee schedule and kind of further exacerbated the need for congressional action. But from a statutory perspective, their limitation on budget neutrality and the fact that there isn't an inflationary update included in that fee schedule like there is for other fee-for-service payment in Medicare really limits what an administration can do beyond kind of picking, certain types of care over other types of care.
Mm-hmm. That's a great point. Yeah. Kevin, let me bring you into the conversation around prescription drug questions. And so the question is kind of the anticipated impacts of recent federal actions around Inflation Reduction Act and the Trump executive order we saw on April 15th. Kind of what is your expectation on the impact overall on drug pricing, rebate negotiations, and kind of how people should be thinking about formulary design? Any thoughts on that?
Thanks, Jen. Yeah, it's been interesting to see this administration, having been so active the first time they were in power on drug prices, seek to reset coming forward after the passage of the Inflation Reduction Act. So So I think folks have been watching signs to see how the Trump administration was going to handle the IRA. The executive order makes clear they're continuing a lot of those policies and seeking to enhance some of the price negotiations, while also looking to do things that would bring back some of their prior policies. So there's a model in there to look at some international pricing. Trump used to call it most favored nation, can be more of a pricing index, something that we're helping some folks to model. There are also pieces in there relative to 340B drug pricing, with requirements for some of the community health centers to pass those discounts along, and also some hospital acquisition cost studies to really kind of maybe bring back some of those 340B cuts that the courts had overturned before, but could also seek to reduce payments to hospitals more broadly for drugs covered in the outpatient setting. So a lot of things in there are executive orders telling the secretary to do things. There are also pieces in there that require congressional action. So there's this thing in the IRA called the pill penalty, where the negotiation delay differs between pills and biologics. And so people have been trying to equalize that, because legislation's required. Who knows what Congress will do and whether that will be about equalization or more of an equilibrating to try to do it in a budget neutral way. So lots of really interesting things that my clients in the life sciences industry and other stakeholders are really going to have to watch, because so much of it, as a lot of the rest of the questions we've been getting, are to be determined at this point. But really will be an active couple of years for drug pricing issues.
Thank you. All right. We had a lot of questions around dual eligibles, around Medicare, Medicaid integration, around D-SNPs. So let's maybe spend a little bit of time on that. Holly, I'll go to you first in terms of, what is the outlook? There's, some concern about some threats given some of the Medicaid cuts or potential changes that Shannon mentioned at the outset. So maybe speak a little bit to, just the outlook for dual eligibles generally in this time in this administration.
Thank you for giving me the opportunity to read tea leaves, Jennifer.
That's what we do, right?
Exactly. Thus far, we haven't necessarily seen any major changes in directions in duals and D-SNPs and efforts around dual integration. We know that the Medicare Medicaid Coordination Office was definitely impacted with layoffs, that there have been changes to some of the CMMI models that are no longer going forward, and that I can envision a future where some of these changes that will have an impact on states, where states that are moving to promote integration, that they rely on CMMI, CCMO for technical assistance. And to the extent that there has been a reduction in staff, that definitely will have an impact. I think the other piece is that as states have more pressure themselves from a budgetary perspective due to cutbacks from federal funding, potential cuts to Medicaid, this could limit their wherewithal or financial means to invest as much in terms of dual integration efforts. It really comes down to the implementation. That takes a lot of work and cost on their part, but it could also put pressure on the states to try to promote integration, and really with a focus on trying to push more responsibilities and therefore costs onto the integrated plans that are covered by Medicare. I think, though, that overall, if we look at the final rule, there were a number of proposals that were finalized in the final rule for this year: integrated ID cards for AIP plans, integrated HRAs. All of those suggest that there's nothing that would tell us that they want to change direction, and that, clearly there are things that we should put on our radar screen as we think about this. Again, wearing the hat of if the federal government is going to put more focus on program integrity, other things, but I would say really looking at plans, the distribution, I guess, of costs between Medicare and Medicaid, and making sure that things are being attributed correctly. There are going to be rate pressures no matter what, I think, even though the rates on the Medicare side certainly have increased. But I do think that there's some chance that there could be efforts to reduce some of the redundancies. Those of us who work in this space closely know very well that it's often that regulatory overlap that doesn't work well that makes it difficult, and that to the extent that the federal government really is committed to relooking at some of the regulatory requirements and other things, this could actually help. And I think the example of only requiring one HRA if somebody's enrolled in an integrated program is a perfect example. I know, Shannon, did you have anything to add to this? Because you're shaking your head.
Yeah, you make a lot of great points, Holly, and just a couple of pieces to add on. I think there's been some discussion of, do some of the functions that were within MMCO, do those go under something like a CMMI in the interest of, further streamlining some of those functions? We've talked with, folks at the state level, plans and others that have seen some difficulty in this transition because of how, kind of unexpected some of those changes at MMCO were. And, most of the states that were in the financial alignment initiative, they're winding down their programs this year. And so it's a, potentially significant loss of data without more input from that office. So they're still kind of working out some of those kinks in terms of where that falls from an administrative perspective. But, I would tend to agree with you. I think that there are lots of opportunities for this population to, provide better care. And when you think about some of the priorities of Secretary Kennedy and Dr. Oz, right? Like, a population that's 13 million that has really significant costs, a range of chronic conditions, and some really complex regulatory requirements that are difficult for states. There, I think, are a lot of areas, whether within their deregulation initiative or some of their aims at, better streamlining these things that they can do. From a state perspective, though, I think that there are some key challenges, right? You sort of spoke, Holly, to some of the capacity challenges that states have. They've had those for a very long time. MacPac has weighed in the past to say that there needs to be resources specifically allocated to states so that they can better focus on integration and have some of those plans in place in a way that they don't today. Some states do, and some states have, participated in things like the FAI, but others, there's just truly a range in terms of how they're approaching integration. And then when you think about, the potential for impacts to states based on Medicaid changes from budget reconciliation, you think about duals. The kind of core coverage requirements don't necessarily go away, but you think about changes states may have to make in terms of home and community-based services, long-term services and supports. Those are some of the key areas that duals care about and are important to those beneficiaries. So, thinking about it from that perspective, I think that there's, some significant disruption that we're seeing expected, but also those opportunities, Holly, that you mentioned on the regulatory side too.
There's a kind of a specific question in the chat around D-SNPs. So I think you're kind of addressing some of that. But there were a couple questions on, just sort of the future direction of D-SNPs and roles and responsibilities, et cetera. Any additional thoughts on that?
I guess in terms of sort of changes in responsibilities, as we know, and it goes back to states control Medicaid and federal government controls Medicare. So in terms of the responsibilities for administering and managing the program, unless there's a fundamental change, I don't think we'll see that will go away. But I do think that from a plan perspective, that plans really need to be looking at what does integration mean. And that, because right now, and again, I say this from somebody who's been working in this space for 30 years, that plans often run parallel. And if you look through, some of the regulations that are out there, even today, the concept of member-centric, other things like that, and the intent or vision around integration, where today an awful lot of plans that have Medicare and Medicaid plans, they may run them in parallel. Even if for an integrated program, we've all seen plans where that Medicare is on one platform and Medicaid is on another platform. To be efficient, to respond to what's happening in terms of rate pressures and other things, plans really are going to have to change some of that, where 1+1 shouldn't equal 2, but in the ideal world, in an integrated model, it should be 1.5, is the way I always sort of describe it. But I do think that there are absolutely opportunities here, and that, but I don't think it's, again, I'm not close enough from a regulatory perspective, and Shannon, from legislative, Shannon, you may have much more insight, that the world is going to change to all of a sudden having this third iteration where it's not Medicare or Medicaid.
Yeah, Holly, I think you're spot on in terms of kind of the regulatory direction we've seen, kind of moving away from some of the integration efforts in FAI towards, how do you just heighten the level of integration through D-SNPs with HIDE and FIDE and some other requirements over time. When you think about the legislative landscape, there have been, introduced bills and some efforts over the last few years to think about, what is that future state, is it a new title of the Social Security Act specifically for, a dual specific plan? Is it more requirements for states to develop specific plans? When you think about that legislation, there's kind of two pieces of legislation, one introduced in 2022 called the Comprehensive Care for Dual Eligibles Act, introduced by then Senator Brown and Portman. And then Senator Cassidy, I think, given some of the changes in Congress, is one of the key champions on duals issues. So he worked with a group of 6, bipartisan senators over the last couple of years, and they developed the Duals Act, which is focused on, really requiring states to come up with a more integrated option than what exists today. Still kind of working through what that financing exactly would look like. But, there is some legislative interest in not just how do we improve D-SNPs and how do we, improve the coordination between the two programs, but longer term down the road, is there more integration that can be provided so that there's less complexity for beneficiaries in the long term. So we continue to monitor that closely and talk with folks about that on the Hill as well. And happy to answer any further questions that folks have there too.
Great. Let's talk about quality. There's 2 questions that came up here, about kind of star ratings measures and then sort of generally quality. Zach, I know you answered it a bit in the chat, but do you want to talk, maybe build on that, build on that a little bit in terms of how you think quality measures will be moving forward over the next year or so?
Sure. Yeah, I think the quality measure question was about what's happening on the fee-for-service side of the regulatory process, and how we're seeing some change in quality measures across the different quality programs of inpatient. My response to that question was, and actually the question was, will measures be added? Will measures be subtracted? Is there kind of a wholesale change coming? It looks to me like the motivation is to make the quality reporting process more efficient and less burdensome for providers, which is a great idea. If the idea is, though, possibly to remove a bunch of measures, that's unclear. What we've seen is that there's maybe an effort to consolidate some overlap. So if we can reduce redundancy of the various inpatient measures, it seems like that might be the inspiration. It seems like maybe there's a chance to add new measures if they're more efficient than what has been used. I'm going to editorialize here and say claims-based measures might be more popular in that environment because there's less burden on the provider to have to put information together and report it off to CMS or the state. So I could see maybe a streamlined approach going forward on the provider side.
And just to add, it's also this Zach was saying, the general movement to digital quality measures to be much more with the interoperability and much more electronic transmission of them. Again, to just be more efficient, reduce the burden. So I expect that seems to be something that this administration and Dr. Oz have been interested in. So I expect more to be coming from that.
On that topic, on digital quality measures, it just struck me as you said that. I mean, is it just that we're going to use things that we already have digitally as quality measures, or are there particular new measures that are being designed that can leverage a more digital environment?
This is
I
a little
concur,
bit
yeah.
out of my area of expertise, so others should jump in, but I think it's a little bit of both. I think it gets to the like burden issues that we don't, are these measures, that we exist, are they measuring really what's important? And what does it mean for the provider to have to submit them? And then how are providers, plans, others being held accountable for what's coming from that? So trying to find a just overall more efficient way of doing it. So it could be new measures. It could also be a different way of just operationalizing the collection of the information.
I agree with you, Amy, and I think that part of it is also as we shift from a hybrid measure, let's say in HEDIS, where you pull a sample of 400 records. Now we're talking about having 100% of the denominator, so all of the members that actually would qualify for a certain measure to be included, and that what this to me does is really mean that the plans have access to data focusing on outcomes, and it allows us therefore to really be looking at the addition of other measures that focus on those things that count, and moving away from some of the administrative measures, because the idea with interoperability and the digital quality measures is that no longer retrospectively going back and saying, oh, do we have these data? It's on a concurrent basis, being able to pull that data and use it much sooner and much more effectively in collaboration both with members and providers.
And I should point out that our digital quality experts are not on this call, so we could defer additional questions on that. Sorry to throw a curveball, but seemed like an interesting question. So there's a couple questions about staff reductions, and maybe just to focus a little bit on what are you as especially folks, some of you have worked inside CMS, certainly worked around it. Where do you see or are you concerned about, the impact of staff reduction in terms of kind of regular order? Are there areas in which you think may be particularly impacted more than others, or, any areas that you would flag for folks there?
So maybe I can start from thinking from my time at CMS, it's not totally clear where everyone has been, where the rifts were and where people are gone, because there's, but as we sort of come to a greater understanding of that, it seems that the folks in the main centers of CMS who generally are doing the work of Medicare and Medicaid were not affected, but it was more of the cross-cutting office work that may have been seen as support or not key central to the work. But I'd have to say that's not really true, because if you need a contract, you need people in the Office of Acquisition and Grant Management, or you need people in the regulatory affairs side, or need people, in the Office of Communications. Just it all goes together to support the development and implementation of the policies. And so I think that's where the folks who are at CMS still may struggle when they're trying to get their rules out or let contracts for, support of a model, or all the different things that those parts of CMS do. They'll have to adapt to their new normal or their new status quo of what that looks like, and whether it be doing more sort of work in the communities from CMS Central if the folks in the regional offices aren't there. So we'll just have to revisit the way they normally have done things, and and also then be much more clear on the priorities of what where the folks who are left, what they will be doing and what they need to be doing. Always we all do the nice to haves versus the need to haves.
Yeah, Amy, I think that's correct there in terms of kind of what they've looked like so far. So, folks will be aware, in the grand scope of the number of reductions we've seen at HHS, some of the CMS reductions and planned reductions are more modest than agencies like FDA, CDC, and NIH, but still have a very large impact. We are aware of a number of folks who were removed in the first round of RIFs because they were in their probationary period, and kind of an unfortunate loss, because some of the most excited, enthusiastic federal workers coming in are removed from programs within CMMI, other areas working on IRA implementation or other pieces. And I do think that there is sometimes a lack of understanding of the importance of some of those support functions and kind of all the different roles that folks play within those agencies. But when you think about a CMS compared to what we have seen so far at FDA and what is further expected through the OMB passback at FDA, you're seeing, significant reductions in the size of the agency. You're seeing that, they're keeping certain reviewers that are necessary to be kept at the agency because they are funded by user fees, but all of the support around those folks that is necessary to approve drugs is going away. You've seen entire programs, in tracking at CDC that have gone away. You've seen, I think, plans for real reduction in the number of programs at NIH for research and kind of streamlining them into 3 main offices. So all that to say, I think, all of these changes can be disruptive, but kind of compared across them, CMS is a little bit less so than some of the other agency changes that we're seeing proposed and that have happened already.
And just to add one more point to that, that will have effect for CMS and the Medicare and Medicaid programs, because CMS is reliant on FDA when they're thinking about coverage of new technology, what's gotten approved by FDA. They have a lot of joint initiatives, or using the experts in NIH or CDC on supporting different programs. So there's a lot of other interaction between those. So I think it's, as Shannon said, the CMS hasn't been cut nearly as much, but when this all shakes out, a year from now or wherever we end up, it will have also implications for the Medicare program as well.
So that sort of takes us to I think the maybe the final set of questions here. We've gotten a lot of great questions, but all of you as experts in your various domains, I'm sure you have questions that you're asking and that maybe people should be asking. So my question for each of you would be kind of, hot takes, maybe a minute or so each. We probably have time for a minute each. What are the questions that clients really should be asking? And what are the things that you are looking at most closely that you think could have a big, positive or negative impact, but kind of a significant impact? Who wants to go first?
Well, I can go first, Jen, and this is low-key a question I was thinking about asking Kevin offline, but for the benefits of having us both on this webinar, maybe I'll ask it here. When we think about the drug pricing executive orders, there's this push and pull within how the Trump administration seems to be thinking about the IRA when it comes to a desire to achieve deeper discounts, but also to protect innovation and to solve some of the current problems within the IRA. Some of it seems like, messaging, right? The IRA was passed under the Biden administration, and there's a need to point to the problems with Medicare drug price negotiation, but there's largely similar goals from the Trump administration. So I've been wondering more philosophically how they're squaring that circle in terms of, we want to protect innovation, but at the same time we want deeper discounts. So is that really achieved through something like an IPI or some of the other models that they've explored in the past?
Really great questions, Shannon. And I agree with you that a lot of it is in terms of messaging, that they want to meet all of these goals. And then what happens when they actually go to move the policies that are actually going to try to achieve that. Because I know pharmaceutical manufacturers think that, if you're going to cut prices more, you're going to cut innovation more. And CBO and others have modeled out, what the impact is, what the drugs are that are lost, and that generates concerns from people. But you're absolutely right that they're also looking to return to different things they've done before to leverage discounts, different ways to get seniors lower prices, such as drug importation. So that they're willing to put everything on the table. And then the question is, what actually comes out of that when it's a regulation, when it's a model from CMMI, or what is Congress going to do? Because some of this stuff does require legislation, and you talked about all of the different budget targets and issues that people have, so I don't think that a lot's going to get done that has a cost to it. So some of the things like fixing the pill penalty, that costs money unless you're really just equilibrating across drugs and biologics to put them all at the same, or coming up with some other kind of pay for to do that. And I guess I don't want to get too political, but some of the things that they're trying to do will take time, and this president seems to often really enjoy, quick results. And so what I'm going to be wondering about is what comes next in terms of what's going to be a really quick result. And so some of the CMMI stuff could move faster, but even that still takes some time. So it's going to be interesting.
Yeah, and one final note there on what you said, Kevin. When you think about the congressional changes, I think Ways and Means, when they put out a menu of options for reconciliation, they lumped a number of changes to the IRA and Medicare drug price negotiation together, but they were looking at a score of around 20 billion in terms of what it would cost to make those changes. So when you think about some of the challenges with what Congress is trying to achieve in savers and then what that might cost, that's certainly a consideration. I'll also throw in the chat for folks. When we think about how is the administration thinking about something beyond what President Trump says or an executive order, looking at folks like the America First Policy Institute, they came out with a brief on some of these drug pricing options. So I'll just throw that in the chat as a reference, but we will continue to monitor what they do on these issues and with drug pricing over time too.
Tim, you look like you had something here.
Yeah, no, I was gonna build on a question that was addressed earlier in chat with my final question for what comes next, and continue with the theme of risk adjustment. I think it's interesting to consider that it's the one area where there's sort of glaring signals like, hey, we're going to ramp up scrutiny. We're going to really make sure that plans aren't taking advantage of incentives. But it's interesting, in order to do so with the historical mechanisms like RADV, it's quite administratively burdensome. And historically, it's been quite ineffective and exposed to significant litigation risk. So I'll be very curious to see what approach CMS uses to address some of those perceived or real risk adjustment issues. And I'm curious to see where the RADV process lands. It's kind of a wacky dynamic to consider that coding from 7, 8, 9, 10 years ago may be creating consequences in this day and age, in an environment where pretty much every plan is significantly behind target margins, and folks in the general world may think of for-profit publicly traded organizations as having these huge targets, but as Humana talked about this morning, their target margin is 3%, and they're not going to get there for another few years, even in the best case scenario. So it'll be interesting to see where that all shakes out. There's a lot of complexities, but if administration or administrative simplicity is a priority, then they're going to have to take different approaches than they have in the past.
Yeah, great take. Holly, we're almost out of time, so sorry, you guys.
I'm just going to add to that I do think that sort of interoperability, the digital quality, and even adding an AI may actually be game changers in being able to almost require upfront that data be submitted along with, if it's encounters or RAF data, whatever it might be. But to Tim's point, that's going forward potentially, and it will take several years, not going back. And so that we're going to be in this sort of a period of time when we have old-fashioned ways of doing things that impact future reimbursement for individual plans. So I'd be curious what others think in terms of the opportunities that go there with leveraging some of the things that we think are good in terms of interoperability and other things like that. I know we don't have time though.
The next one. We'll take that to the next one. Zach, and then Amy can finish us up. Zach, any hot takes?
No, I think it's just really important for the providers out there to keep an eye on what's going on with site neutral. That's the hottest topic to me right now in DC.
Okay, that's a good one.
I would add, Innovation Center wanting to talk about models that save money, and there's things you can do to make models save money, like mandatory models or other, benchmarking that, so will they be successful in that they can have models that are going to save their money, but also have robust participation? But sort of the bigger picture to end it on this is like, will Medicare really not be touched at all? And, what does that mean for solvency of the program? And, we're coming on to the 60th birthday of Medicare this summer. What does the future really hold if, value-based care is not the answer, Medicare Advantage isn't the answer to save money to make it. So lots of open questions and sort of that big picture that doesn't seem to be really a topic of focus right now, but there's probably already so much stuff that is a topic of focus. There's no space for that right now.
Yeah. Lots of questions. Some we answered, probably many more that we didn't. If you have additional questions that we didn't get to today, please feel free to send us a note. And hopefully you come away with some new insights and perspectives, and also a sense that this team is pretty well suited to answer all sorts of questions or concerns or help with opportunities. So please let us know how we can be helpful. We will share this recording link, so please share it with anyone else who may benefit from it. And the end of next month, we will be doing a similar town hall on behavioral health, a topic that was asked about and certainly related here, but has lots of contours of its own. So look forward to that. So thank you, all of our panelists and those who posed questions. We appreciate the dialogue today. Thanks so much.